So on behalf of Translumina, thank you all of you for joining, and it's our pleasure to host this evening and this webinar, especially on DCB in Era of Modern PCI. Before I hand over the session to Dr. Manokar and Dr. John, I'll just take you through our Translumina journey. So we incorporated in 2000, and currently we have presence in more than 50 countries. We are third time certified as Great Place to Work. Currently, we have 5 manufacturing units, one in India, Germany, and then in Netherlands, in which includes 3 indigenous manufacturing units. R&D, we have association with German Heart Centers. We have 8 strategic partnerships. We all know about it: IVL, Asahi, Sys Medical, etc. We are the only company probably in the world with 10 years data of safety and efficacy on stents. All of our products are CE certified, and we have more than 1 million implants in terms of DES. Giving a short brief on Blue Medical and Translumina. So Translumina has further strengthened its technological portfolio by acquisition of Blue Medical Netherlands, and now it is a Translumina group of company. This acquisition happened in last year October. Giving a brief on global perspective of Protege, which is the paclitaxel coated balloon. Currently, Protege is present in more than 35 countries. We have R&D team and manufacturing team based out of Netherlands. The product is EU MDR CE certified, and the technology is patented technology of Translumina. Coming into the session, so this is the session today for DEB Talks, and we'll be, I hope and wish forward that this will be a very interesting session for the audience and for all of us. Introducing, the expert panelists, Dr. John F. John, and the moderator, Dr. P. Manokar. I hope he joins the session soon. Dr. John F. John does not need an introduction. He is, already he's a senior consultant, and he has 18 years of experience in intervention cardiology, and he has rich experience in all complex procedures of angioplasty and arrhythmia management, structural heart, etc. So, Dr. John, in absence of, there is a little delay of Dr. P. Manokar joining the session. So, I request you to lead the session, sir. Thank you.
Before Priyanka, thank you very much. Before Dr. John takes an act as a moderator of the evening in the absence of Dr. Manokar, I would take this opportunity also to introduce Dr. Oscar. Sir, Dr. Oscar is basically a leading intervention cardiologist from Poland, and he has been associated with University of Clinical Hospital at Wrocław. Dr. Oscar has been associated with Institute of Heart Disease, and especially if you look into the credential of Wrocław for research and publications, it basically holds an experience of lot of apart from that, Dr. Oscar holds a lot of experience working with military clinical team. And let me tell you, today we are joined by some myriad of great people, apart from Dr. Oscar joining in from Poland, especially from people from India, like Dr. Jabir sir, Dr. Arun Gopi sir. They are one of those few stars in India. And what we have done, sir, that basically what today is we are doing is a DEB Talk. Basically, DEB Talk is a platform we have created and curated. Basically, we are going because we believe that this subject requires a lot of intense discussion rather than extensive discussion. So that is why at this point of time, although we are beaming this to audience all India and internationally also, but at the same time, our discussions, the speakers and the faculty are only as if we have gone bit of a region wise. The idea of bringing this region was to see that how do we basically we have the views from region to region, and then we are trying to collate once again nationally, and then we are again going to talk at the national level. So this is a humble start from our side as a team from Translumina to take this to bring a lot of intensive discussion rather than going extensive, and bringing in faculty from all over the world and joining with this team and creating a discussion. Now, having said that, now I would hand over this session to Dr. John F. John and to invite Oscar sir for the program, and we continue with all the speakers of the evening. So over to you, Dr. John.
Thank you. So today, I'd like to first of all invite all the speakers. A very good evening, and today we have this session on DCB technology, this platform will give us the insight into the newer technologies and future prospects of drug-eluting balloon technology. Even though this has been available over the last 10 to 14 years, and even though it was used initially for treating in-stent restenosis, now the area of DEB has expanded to diffuse disease, small vessel disease, branch vessel treatment, etc. So today we have 5 talks, and I suppose all these talks will give us a clear insight into the various aspects of drug-coated balloon technology and its prospects in our present interventional practice. So I'd like to invite Dr. Oscar for his first talk on DCB insights into emerging technologies. Over to Dr. Oscar.
Hello, good evening, everyone. My name is Oscar Akoto-Arison. I work. Can you see my slides?
Yeah, we can see your slides. Yeah.
Okay. I work in the Institute of Heart Diseases in Wrocław, Poland. And today I want to talk about drug-coated balloons as emerging technology. This is my conflict of interest. So what we already know, we use drug-coated balloons in in-stent restenosis from bare metal stents and drug-eluted stents. This is recommendation from 2018 myocardial revascularization guidelines from European Society of Cardiology in first class in level of evidence A. But the time passes and we have a new indication for this instrument. So I will show you some cases. First one is 62-year-old male with hypertension, hypercholesterolemia, obesity, who was admitted to our clinic due to inferior MI. First, we perform coronary angio and we reveal totally occluded right coronary artery. My colleague treated this patient with drug-eluted stent due to not enough lumen after the ballooning. First, we performed the predilatation of the lesion in the LAD with 2.25 and 2.75 balloon, and then performed the inflation of DCB protégé 2.75 for 60 seconds in the LAD. Then we go to the ostial lesion in the diagonal branch. So we perform 2.0 and 2.5 inflation with good result, and then we proceed to inflation for 60 seconds with 2.5 protégé DCB. And this is the final effect. So we just wonder about this lesion in the LAD just after the diagonal branch, but we didn't see the stenosis which caused the limitation of flow. So we decided just to let the patient go out, and if he will have some angina, we will probably measure this lesion. We have here the aspects of two stent technique and provisional technique. There is a lot of steps during the procedure, but using your DCB, you can really simplify the complex. So this is the indication for the drug-coated balloon, especially for young doctors with not a big experience in two stents technique. What's more, here we have the patient with small vessels. So what we already know from Piccoletto 2 trial, that patients with vessels smaller than 2.75 treated with drug-coated balloon have a lower rate of MACE in a 3-year follow-up, as well as in the basket small II trial, we can see that patients with smaller vessels, lower than 3 millimeters, have not inferiority of drug-coated balloon treatment alone. What's more, these patients have multi-vessel disease, and this trial showed us that DCB-based group have a smaller rate of MACE in 2 years follow-up, comparing to death-only group. This paclitaxel drug have a shorter half-life, so it causes lower toxicity to vessel and have a quicker vessel healing, so we can reduce the adapt timing to our patient, especially to patient with anemia. What's more, the Protégé drug-coated balloon also have unique drug application, so it can prevent loss of drug during the delivery, and also delivery is easier using this balloon. We can use it up to 3 times. And the second case I want to show you, it's the 70-year-old male with lots of comorbidities, with heart failure, hypertension, COPD, atrial fibrillation after stroke with anemia, who was referred to our facility from other hospital due to CCS3 angina, chronic coronary syndrome. Colleagues performed the coronary angio, which revealed the chronic total occlusion of LAD as well as the circumflex. And we discussed this patient on our heart team meeting and decided to perform the PCI CTO of LAD. So we proceed with integrate wire escalation using Scion, using Fielder XTA, and finally Gaia seconds, and we pass through the chronic total occlusion, and just to the end of vessel. And then we perform multiple predilatation of this LAD with a good result. So we decided just to go to DCB inflation for 60 seconds in the proximal as well as in the medial part of the vessel. With such final effect, we will see how the patient will go. We planned to perform the coronary angio in 3 months, so we will see. But what we already knew from trials, the long-term clinical outcomes of drug-coated balloons, of management of chronic total occlusion are not inferior to hybrid one using the drug-coated stents and the drug-coated balloon. So we can avoid extra metal to the patient. What's more, we can see that after the angioplasty with drug-coated balloon, we see that minimal lumen diameter is higher after some time. So we will see the patient will probably have a bigger vessel after these 3 months. What we know from this consensus group. So you can use your DCB when you use balloon to vessel ratio of 1:1. You have to prepare the lesion with maybe non-compliant balloon, scoring balloon, cutting balloon, or even rotablation, orbital atherectomy, or even lithotripsy. You can use DCB when you have no flow limitation and the residual stenosis is lower than 30%, or you have FFR higher than 0.8. What is the take-home message? So you have to consider the drug-coated balloon when you have the intra-stent restenosis, so what we already knew. But the new indication for using this balloon as small vessel, bifurcation, multi-vessel disease, high risk of bleeding, young age, and you can use it in the CTO patient as well. So thank you for your attention.
So thank you, Dr. Oscar, for that nice talk. Can we have the questions at the end, because we are already running late?
Okay.
So the next talk is by Dr. Jaber Abdullakuti. Will DCB replace drug-eluting stents? DCB data beyond ISRs. Dr. Jaber?
Okay, thank you, Translumina, for this great opportunity. What we have heard from the previous speaker is that drug-eluting balloons, which was introduced long way back, maybe perhaps I think it is 12 years ago, and most of the data are quite old now. We are generating new data. So we had a balloon era, from where, because of the problems of the balloon, we shifted to the stent era. Now the stents have got an advantage because of the drug. The scaffold helps to protect us from the recoil of the lesion. The drug with the, of course, the disadvantages of the polymer could prevent a restenosis. So that's the edge of the drug-eluting stents over the balloons, and drug-eluting stents have become the standard. But drug-eluting stents cannot be used in all situations. A small vessel, sudden bifurcations, and of course the Achilles heel of the drug-eluting stents, the restenosis. So is there any point of using drug-coated balloon in those situations? Now the world is thinking, or the world's thought process is changing. Are there certain situations where you can use the drug-coated balloons, where you can deliver the drugs, you can take away the disadvantages of the drug or the persistent polymer as well as the metal. So let's see whether we can resort to the use of this new device. I'll not say it's a new device, it's an old device with new indications and coming back with a big bang all over the world. So it's a drug, this was discussed before, it's a drug delivery over a very short period of time, and it's avoid chronic inflammation due to the absence of polymer. One of the disadvantages of the drug-eluting stent is the polymer, which produces inflammation, and of course the lack of endothelialization. So better re-endothelialization, reduced need for a long-term dual antiplate therapy for the drug-coated balloons, and most important thing, there is no distortion of the original vessel anatomy, and no double or triple metal layers in case of ISR, and easy lesion crossing, deliverability by balloon only, and of course it's an useful technique in case when there is a high bleeding risk. So I'll show a case. This is one of my case, the LAD. We did, though the lesions look like a borderline lesion, the IFR you can see it is 0.6 and the FFR is 0.7. We did a stenting, a drug-eluting stent across the diagonal, so it's a crossover stenting. When we did the IFR, we didn't want to cross the second diagonal because we thought that's the last diagonal and the major diagonal. The last and the major diagonal is important, because there are no diagonals beyond that. So we did the OCT, but when we did the OCT, we could find that there is some problem in that diagonal ostium. The stent is well deployed, there is some amount of calcium, but there is an issue beyond the diagonal. So we put another stent across the diagonal, And when we put another stent across that diagonal, you can see what happened. There is a significant pinch of the diagonal. So when we saw that significant pinch across the diagonal, we thought we have to dilate the lesion, do a ballooning. So we thought it is better to avoid the it is better to avoid another stent there. So we kissed it with a drug-eluting balloon. So drug-eluting balloon in the diagonal, kiss it with a standard non-compliant balloon in the LAD, and then a port, and it was a good result. This is another case where it is an ACS, occlusion of the LAD. We opened up the LAD, we put a drug-eluting stent, wiring and protecting the diagonal, but we have there was an issue with the diagonal. So again, we put a drug-coated balloon of 2.5 millimeter to the side branch, and we did a kiss, and it's a good result. And you can see what's there in the OCT. It's a decent result, a well-deployed stent without a luminal problem, without an edge problem, and the bifurcation area is also well protected with a drug-coated balloon. And another patient with a ACS and a 2-vessel disease, the circumflex we stented, LAD, a crossover stenting. There is a significant pinch of the diagonal. So we put a drug-eluting balloon or a drug-coated balloon to the diagonal, and you can see what happened after putting. So every drug-coated balloon usage is not without a payment. So sometimes there is a cost to pay. There is a significant dissection with the use of drug-coated balloon, and then we repaired that this dissection was covered with another 2.5 millimeter drug-coated drug-eluting stent. You can see the significant dissection. This dissection we cannot let free. Though people, when use drug-coated balloons, we see a lot of dissections. If it is not a flow compromising dissection, if it's if we don't feel it very relevant dissections, we may leave it even after imaging, because if you do the imaging, we'll see a lot of dissections after the use of after preparing the lesion and the use of the drug-coated balloons. But this is a dissection which we cannot leave alone, and we used it. So this is something called a bailout stenting. So in the philosophy and bifurcation stenting, it's always better to leave a low metallic burden, and provisional stenting is the default strategy in majority of the cases. When you use a drug-eluting stent, there is a metallic arena in 2-DES strategy, and there is a non-uniform distribution of the drug on the arterial wall, which is maximum at the struts and lowest between the struts and the margin. And there is always an issue of late stent thrombosis and loss of vasomotion. And when you use a side branch drug-eluting balloon in a bifurcation lesion, it respects the anatomy of bifurcation. There is no metallic neocarina. There is homogeneous application of the high dose of antiproliferative agent on the entire vessel surface. And there is no main branch stent deformation, is very, very minimal. And there is no crushing of different metal layers and polymers. These are certain advantages of use of a drug-eluting balloon or a drug-coated balloon in the side branch. But there are concerns and queries of the drug-coated balloons. The most important thing is recoil. How long we should wait to see that there is recoil? No recoil. Can there be a late recoil and a problem? What happens if there is a dissection? Which dissection studies which are the dissections not to be tackled, which is the dissection to be tackled, and whether it's only putting a drug-coated balloon first in the bifurcation lesion, open the side branch with the drug-coated balloon, the drug is applied, then go ahead with a provisional stenting technique across the side branch into the main branch, or is it a kiss-in balloon dilatation with a drug-coated balloon in the side branch and a non-compliant balloon in the main branch, or is it a drug-coated balloon in the side branch and a port side drug-coated balloon and then a report? So these are only questions, and in many forums I have heard these questions, but no definite answers, because we don't have a randomized control trial data, we don't have a registry data regarding these questions. Then is it drug-coated balloon and then a crossover stenting? or upfront side branch drug-coated balloon in case of a significant side branch disease? So these are questions which needs answers, but I don't think we have any definite answers to this. So this is another patient who has who presented us with hypertension of 6 months duration and an NACS at the time of presentation. The circumflex, a bifurcation disease. The circumflex bifurcation disease, the major branch is the OM, and a small diffusely diseased distal circumflex, but it's a very long vessel. So we thought the proximal part of the lesion, you can see the main branch proximal part at the bifurcation is free of disease. So we went ahead with a V stenting, and excellent result in the OM, decent result in the circumflex. And it's a distal diffuse disease of the LAD. You can see after the distal diagonal, the distal part of the LAD is diffusely diseased. What to do with leave? Plain old balloon angioplasty, is it drug-coated balloon? So we prepared the lesion with plain old balloon angioplasty and then applied a 2 into 25 millimeter drug-coated balloon, and there is a decent result in the distal part of the small vessel, which is hardly 2 millimeter in size. So the drug-coated balloon, you can use it in patients with high bleeding risk, in small coronary artery disease, in large vessels, especially in bifurcation, distal, the circumflex bifurcation, or for example, the LM bifurcation where there is a circumflex ostial issue, or following a crossover stent from the LM to the LAD, and lower late luminal loss and major adverse cardiac events for the side branch versus a plain old balloon angioplasty, and deaths in the main branch plus a drug-coated balloon in the side branch versus a 2-stent strategy, lower restenosis rate and target lesion revascularization rate. And small vessel disease, lower 3-year major bleeding, lower abrupt vessel closure at 3 years versus a death versus a drug-coated balloon. So there are many indications for these drug-coated balloons now, especially in patients with bifurcation disease, patients with a small vessel disease, diffuse disease, certain cases in which there is a high bleeding risk. So in the small vessel disease, we have plenty of data which shows that this is safe and effective, and a similar risk of target vessel revascularization, target lesion revascularization, and all-cause death. In fact, it was significant, and there was a significantly lower risk of vessel thrombosis. Large vessels, de novo lesions, of course, there is data, but these data are not large studies. Many of them are not randomized trials. So what are the potentials? What is the potential of drug-coated balloons? They have the potential to address the limitations of the deaths in various clinical and technical settings, effective in large de novo coronary lesions where it's a matter of debate because we are worried about the recoil, we are worried about the restenosis. Suitable for bifurcation lesions, mainly for the side branch. Diffuse coronary artery disease where drug-eluting stents may produce the chance of restenosis is quite high. In patients with acute coronary syndromes, in certain situations, especially high bleeding risk, if the patient wants to go for a surgery in the recent vicinity, you apply drug-coated balloon, send the patient for surgery, let the patient come back. If there is any issue, later on we can stent. Patients with high bleeding risk. So the last 2 years have seen significant developments in the drug-coated balloon technology and the clinical data. And there are ongoing large clinical trials with long-term follow-up, which is needed to validate the efficacy and safety of the drug-coated balloon in these settings. Thank you so much.
Thank you, Dr. Jabir, for that nice talk. So you did show us some cases where you've managed these LED diagonal and circumflex OM bifurcations. Do you have any experience of managing ostial circumflex lesions with a drug balloon? Because
in fact, I didn't, because of the time constraints, I didn't show that. Now, in a patient in whom we are going for a crossover stenting from the LM to LAD, in a LM bifurcation disease, if the circumflex gets pinched, now we opt for a drug-coated balloon for a kissing balloon if there is a lesion in the ostial circumflex. If the previous imaging shows no lesion in the circumflex ostium, we just open up with a normal balloon. If there is some lesion, we may go ahead with a drug-coated balloon. And isolated ostial circumflex disease is another situations where we, without using a drug-eluting stent, we go for a drug-eluting balloon only. Of course, I'm sure that there are a lot of questions. What is the long-term result? Will there be a restenosis? Especially the circumflex ostium is one thing that is very, very, it's an important substrate for
Yes, probably we can have the questions. Yeah. Pardon? Okay, thank you, Dr. Jabir. I think we'll move on to the next talk by Dr. Arun Gobi, Maintaining Vasomotion with Drug-Coated Balloons, Lessons from DS and BVS Trials. Dr. Arun?
At the outset, I thank Translumina for the opportunity, and it's a pleasure to be presenting this topic. I'll not be showing cases up. It's just the one of more of explanations why DCB is going to more and more replace the metallic and non-metallic scaffolds, that is maintaining vasomotion with DCB. So while we were made to think that DES was the holy grail of PCI, we realized that we needed to live with this. We started seeing late stent thrombosis because of neointimal hyperplasia, delayed healing, the abnormal remodeling that DES produces, and the new atherosclerosis. So we understand that stent-related events continue to occur at least at the rate of almost 2% per year, about from the first to 5 years post PC, and so there was definitely a need for a non-metallic solution for these coronary stenosis, and that is why the concept in the last decade or more than 2 decades have been on uncaging the coronaries with metalless PCI. The two options in this arena has been the bioresorbable scaffolds and what Jabir sir well alluded to, and had demonstrated was demonstrated in the first 2 talks, that is drug-coated balloon. Bioresorbable scaffolds were more and more appealing in younger patients with typical type A or type B1 lesions with mid to distal arena of the coronaries with a reference diameter between 2.75 to 3 graftable beds, while drug-coated balloons were more and more applied for smaller vessels, instant restenosis, as Dr. Jabir alluded to, bifurcation, side branch healing, high bleeding risk patients, and hybrid PCI. So drug-coated balloons indications are primarily in instant restenosis, small vessel disease, bifurcation lesions and de novo lesions, and they have a speaker. And we have significant amount retain the vasomotion. So what is vasomotion? Vasomotion is the ability of blood vessels to constrict and dilate, which in fact goes a long way in regulating the blood flow and the coronary perfusion pressure. The importance of vasomotion comes from a healthy vasomotion would indicate a healthy endothelial function, and that would reduce the vascular events that happen. And vessels with retained vasomotion responds appropriately to physiologic stimuli, thereby enhances long-term patency and reduces adverse vascular events. So the 3 options for PCI, that is the traditional drug-eluting stent, drug-coated balloon, and biovascular scaffolds. What are its impact on vasomotion would be my topic. So from DES, we all understand that the DES causes chronic inhibition of endothelial cell proliferation and smooth muscle migration. It impairs vasomotion. So the delayed healing that happens with DES, the long-term presence of polymer and the drug which would delay the endothelial healing, it in fact reduces the vessel's ability to constrict or dilate. So in fact, it causes improper vasomotion, and that actually leads on to impaired endothelial function, and there's concerns of late stent thrombosis. So there's been well documented in studies that people with drug-eluting stents tend to have persistent vasomotor dysfunction, and this is in fact considered as etiology behind recurrent ischemic vascular events after drug-eluting stents. What about biovascular scaffolds? So biovascular scaffolds came with a hope that you would have only a temporary scaffolding which would resorb, and then you would be restoring a natural vessel with normal vasomotion. The idea was to restore natural vessel motion after scaffold resorption, but what we found was something on the contrary. We had increased device thrombosis in early trials from absorb. We found incomplete resorption, so the concept that of the scaffold would resorb off and would restore back the vasomotion was taken off because you had incomplete or inconsistent scaffold resorption. And this, because of all these things, there was actually mixed results, some restoration of vasomotion, but not as it was hyped up. So drug-coated balloon comes a long way in maintaining vasomotion because it delivers the anti-proliferative drug to the vessel wall without leaving a permanent implant. The drugs that are delivered actually since they are temporary, there's no permanent scaffold left behind, so there is actually nothing which impairs the natural restoration of vasomotion. There's less impact on the endothelial function, and that's what studies have also shown. Studies have shown a positive outcome with drug-coated balloon in maintaining vessel patency. There's reduced restenosis, better preservation of vasomotion with drug-coated balloon compared to drug-eluting stents. This is actually a prospective open-label single-cell randomized control trial where the randomized limited a small number of patients to a drug-coated balloon and drug-eluting stent, and they actually looked at so you can see the stent arm as well as the drug-coated balloon arm. If the area which was treated with drug-coated balloon is subjected to high-dose acetylcholine, you can actually see there is no excessive vasoconstriction. While if you see the area we have post-stenting, if you subject them for high-dose acetylcholine, you find significant paroxysmal vasoconstriction with acetylcholine that happens because of endothelial dysfunction, and that indicates impaired vasomotion. Both of them dilate nitroglycerin, but clearly this shows that drug-coated balloon retains the vasomotion or the endothelial function, and that is why you don't have a paroxysmal vasoconstriction with acetylcholine. Similarly, this is actually a study which showed the favorable vasomotor function after drug-coated balloon, only angioplasty in de novo lesions, which was earlier alluded to. So from instant restenosis, if you take up de novo lesions, so this was a study on about 132 de novo coronal lesions, in which 110 were analyzed for vasomotor function with ergonovin provocation test. You can actually see the culprit lesion, what happens after it was treated with DCB, and the area which was treated with DCB when they were given ergonovin, there was no paradoxical vasoconstriction. So you took at the so what we find is what DCB does is you make the lesion area almost like a normal vessel. So it responds the same way as a normal healthy vessel, or and on the other hand, the areas which are treated with stents or virus-coated scaffold tend to have vasospasm with ergonovin. They have impaired endothelial function. So there are significant differences which were observed against the spastic counterparts. The DCB-treated vessels and angiographic normal segments had proper vasomotor function. So one strong proponent in favor of drug-coated balloon in the current arena would be the preservation of vasomotor function, because we realize that in comparison to drug-eluting stents, drug-coated balloons have no permanent implant left behind. So there is a better long-term vasomotor function. The drug-eluting stents impair the vasomotor function, leading on to impaired healing and recurrent ischemic events. Bioresorbable scaffold, all we understand that incomplete resorption, and there is device thrombosis, and there is partial resolution of partial restoration of vasomotor function only. But with drug-coated balloon, you have excellent restoration of vasomotor function, and you have the vessel which is treated with drug-coated balloon behaving exactly like a non-disease segment. And now there are more and more ongoing and larger clinical trials with long-term follow-up, which would actually elucidate this physiology concept and making the vessel as physiologically healthy as possible after drug-coated balloon, and that will actually go a long way in reducing the recurrent MACE or ischemic events after PCI with drug-coated balloon. And we have only now limited data, but this is a very promising concept and a very promising proponent in favor of use of drug-coated balloon for not only small vessels bifurcation lesion, but also big, large de novo vessels with stenosis. So that's all from my side.
So thank you, Arun, for that nice talk. So he's very clearly elaborated the importance of maintaining vasomotion while treating coronary artery disease. So I think we'll take questions after that. So the next talk is by Dr. Damodaran. We'll be talking on paclitaxel, the drug of choice in DCB as compared to sirolimus. He'll be giving us a talk on various randomized controlled trials. And so over to you, Dr. Damodaran.
Good evening. Sorry for the delay. There was some technical glitches, so I could not join at the right time. And my talk is mostly on comparison of paclitaxel versus sirolimus. I have heard that I have heard that both the speakers spoke very well about the data on the paclitaxel drug-coated balloon and the comparison. I'm not going too much theory on that. My slide is visible. Am I audible now, Dr. John?
Yeah, we can see your slides. Yeah.
Okay. Let me just when we are discussing about the drug-coated balloon, obviously we have got the concept of metal-free PCI, or the latest terminology, maybe leave behind nothing. But to improve the outcomes of this drug-coated balloon, since when it was introduced in 2006 by Bruno Scheller, we have been on the verge of attempting to improve the outcomes in various subset of patients. We have got data on ISR, plenty of data, and even the ESC has approved as a class 1 recommendation, and trials are there. We are so comfortable with the ISR. But whatever we say, having said that, in terms of de novo lesion, we are still in the primitive, or I can say we have an evolving data only, because when you are asked to do a drug-coated balloon in a proximal LAD or a left main, guy can, like Dr. Colombo, can demonstrate, but for a real-world practice, we have our skepticism and reservations. So, having said that, whatever the indications and the evolving indications, if you want to improvise the outcomes of the drug-coated balloon, it is not only the drug that matters, because the drug alone cannot do. Obviously, the recent studies have analyzed, the retrospective analysis of the recent studies showed that whatever the failures in the early generation drug-coated balloon is not due to the drug per se, it is mainly to the lesion preparation. So, I want to emphasize the lesion preparation is the main important determinant of all these drug-coated balloons. So we have to relearn how to do an angioplasty before going to the drug-coated balloon. So there are two drugs, everyone knows about that, and the clinical data on RCT and a lot of registries and real-world registries. And let us just delve into the mechanism of these two drugs. You all know that, but still I want to refresh it. The paclitaxel irreversible binding, that drug is being transferred to the lipid bilayer cell membrane into the intracellular area, where it that binds with the microtubules, inhibits the cell division. So obviously the smooth muscle loss, apoptosis happens. This apoptosis is being histopathologically being measured as a smooth muscle cell loss, as well as the preclinical animal model as and muscle to artery ratio. That is what I'm going to talk about now. And this paclitaxel compared to the sirolimus has a strong anti-proliferative action and moderate anti-inflammatory action. That is why when we talk of so much of theory, we need to also look into whether it is really clinically translated into benefits or outcomes. That is what we are still lagging in the de novo lesions in the DCB. There are a lot of trials on late human loss, but where is the question of the real comparable data or superior data when compared to DES? That is what we are going to discuss today. So the other important thing of paclitaxel is prolonged tissue retention. Obviously, lipophilicity and the tissue retention property obviously keeps this drug into the vessel wall when compared to the non-target area myocardium. So the cell proliferation is obviously persistently inhibited. And coming to this kind of data, you all know that starting from BMS ISR, BS ISR, and also the small vessel disease, and there are some imaging data on large arteries also, but we need to, when we are talking about large arteries, I always want to emphasize that we need to do not like apply an old style angioplasty. We need to use the physiology and imaging to guide or to assess the outcome, both acute as well as in the long term. So the preclinical data of these balloons, the two type of balloons along with the sirolimus coated balloons, has shown that the smooth muscle loss, which is an indicator, is more in terms of paclitaxel coated balloon when compared to the sirolimus coated balloon. The obvious explanation is more apoptosis due to the strong anti-proliferative action when compared to the sirolimus. Also, the muscle to artery tissue. That means the non-target tissue to the target tissue. Because the sirolimus is the one known to have more, the drug is lost more into the downstream, into the myocardium rather than on the tissue. That's why the muscle to artery ratio, otherwise called as non-target to target tissue ratio, is better in terms of paclitaxel coated balloon. These are all the preclinical studies by this Era et al. But this sirolimus coated balloon, this muscle to artery ratio, was really not validated. These two concepts were hypothesis generating, but really not validated in any of the clinical studies. So we just should know about the concept, but still not yet validated. So I am not going to much data, only the recent data in 2023, that was in TCT 2023, these two studies were in fact discussed about much. There are two opposite ends of result. One trial says that sequence plays mu as well as the sirolimus coated balloon by Bruno Scheller has shown that the sirolimus coated balloon is non-inferior. The explanation is the coating, the kind of coating they have done. So he emphasized the coating also matters apart from the molecule. So that is how it is showing non-inferiority to the paclitaxel coated balloon. Whereas if you look at this magic touch, which has been failed to show the superiority, and in the trial, it has shown that the late luminal loss and everything is more. So it has failed to show its superiority compared to the paclitaxel, standard paclitaxel secant balloon. So basically, when we are having an emerging data, but still we are not yet there to conclude which is the best balloon tip. For all practical purpose, what I understand, what my translation of all this concept into clinical practice is basically, when I do ISR PCI, obviously the vessel is caged. There is no question of further remodeling that. So I always choose either a paclitaxel or a sirolimus. In those days, sirolimus. Now that there are not much data on sirolimus, so paclitaxel. But when you deal with the de novo, especially in a small vessel which has been proven, and compared to we have much data on a small vessel and compared to a large vessel. So in a small vessel, it is better always to go for a paclitaxel coated balloon because it has a positive remodeling. In fact, the lumen enlargement will be there. In such small vessels, obviously, one can have a better long-term outcome. Let me go to the two of the interesting cases shortly. This is a 66-year-old gentleman with multimorbid guy. Basically, he has a CKD with the AGFR of 20 to 25. He presented with an antivolume, LV dysfunction, and he has multiple lesions, and he is initially subjected strongly counseled and extensively counseled for bypass surgery, but somehow he was not. And one thing is that the distal LAD was not that much graftable, so the surgeon was also not very much happy about grafting the LAD. So we had a discussion, then we wanted to go for an imaging and physiology guided low contrast PCI. And you can see this is the angio which was done elsewhere, and we have uploaded because when we do a low contrast, we always try to conserve the dye. So we will upload the angios done outside, and you can see there is a lesion in the LAD, the moderate lesion in the osteoproximal LAD, and there is the moderate lesion in the LCX, and there is the diffuse lesion in the distal LAD. The distal LAD is diffusely diseased and the RCS. So this gentleman, we then did imaging guidance. We first did a RFR of the OM, which was shown as almost insignificant, and then we went ahead and you can see a little bit of dye as a baseline reference, and then we went ahead for a LAD, and the LAD you see almost shows 0.76, which is significant, and you can see the step up when the LAD, when the RFR was measured in the mid to proximal segment, that it is like almost like a 0.95 something. So it was, so the lesion is mainly in the mid to distal LAD. So we need which was the area which was diffusely diseased, so not suitable for graftability. Then we did a balloon angioplasty. We were starting with a small sized balloon, and we did a but you could not do a pre-angioplasty IVAS because the disease was also tight. So when we did a 2 millimeter balloon, you can see still the FFR was not achieved. It was 0.8. That's where when I looked at the data, literature, there were only 3 studies, to my knowledge, which has taken 3 different cutoffs. One study 0.75, the one is 0.8, mostly on the PDPA, that is FFR. We have also measured the PDPA here. You can see that the FFR is 0.78. And after doing a 2.5 millimeter bigger size balloon, then the RFR was 0.92. And this functional testing rules out 2 things. One is we didn't have any angiographically significant or a flow limiting dissection because we could not do angio. There is no flow limiting dissection. The second one is, okay, we have prepared the lesion well, we can go ahead and do the application balloon, that is a drug-coated balloon, because the drug-coated balloons are only application balloons, they are not dilatation balloons. Then we applied 2 balloons from distal to middle AD. You can see 2.5 into 20 and the mid one is 2.5 into 30. The question is again how much we have to overlap. That is also there. If too much of drug, then it will be whether it is synergistic or toxic and future may cause aneurysm, we don't know. But we have been very careful in not overlapping too much about the balloons. And after the coated balloon application, we again did a RFR. You can see the RFR is 0.97, and then the IVAS showed a recent area of the small vessel, which was almost like a 2.5 to 2.25. So then there was a good dissection, and you can see the RF was 0.98 at the which was measured 10 minutes after the angioplasty. We did a final angio just for a reference and the insurance purpose. So the issue is now that the way we need to do the drug-coated balloon is not just doing like the old balloon angioplasty. The outcomes can be improved only when we do a imaging or at least a functional guidance, which can tell you at the end of the procedure you have done a good job. This is another case. This is a laser-assisted hyperphysiology. The history is very long, lengthy. So I just want to go into the short history of old angio-LMI, moderate LV dysfunction with symptomatic class 3 symptoms. CF is around 40%. You can see this lady had a long CTO. This is the middle part where the stent was there. So there was a de novo CTO in front of the ISR CTO. So there are 2 lesions, 2 CTO lesions we need to tackle, and this was nearly looking like an ambiguous gap. So there was some lesions, this was nearly looking like ambiguous. So we wanted to do it with the IVAS guided wiring, and then we wired it, and then we did initially with the XGA and then microcatheter, and then the Gaia was inserted. It was advanced into the stented segment. This was also technical. The main reason was under expansion. There was some atherosclerosis also, just for the sake of time. Then we dilated here. We applied some laser energies because the instant restenosis was so fibrotic and it was not yielding to a regular INSI balloon. We applied some laser energy. The one thing we have to be, I also learned that we should not do more aggressive balloon dilatation after a laser. It was our initial experience that we got a severe dissection hematoma of the proximal lady where there was some laser energy was used. Then we went ahead and stented it. This is another concept, very novel concept which is emerging these days, that hybrid PCI. If you have a large vessel proximally stent it, and if you have a small diffuse disease, non-graftful disease, then you can go for a DCB. So that is what is called as a hybrid PCI, though we did the hybrid PCI here, and finally the result looks okay, which was again confirmed with this. So in conclusion, obviously, unlike the Castronondo's aggregate meta-analysis, which has a lot of limitations, which has shown that the paclitaxel has increased the mortality, The recent data from various meta-analysis shows that it's a safer drug. It can be used in patients, especially in ISR, as well as in some of the subset of lesions like the previous speakers have spoken about in length, like small vessel disease, bifurcation. And also it gives the advantage of uncaging the coronaries. So by uncaging the coronaries, it gives the advantage of avoiding the late and very late events and improving the outcomes. Thank you.
Thank you, Dr. Damodaran, for that elegant talk. Do you think imaging is important when you plan for a DEB in a large vessel for a de novo lesion?
Yeah, absolutely. Because you see, when we do imaging, obviously, two things we are sure. Obviously, we will do a pre-PCI pre-planning. That is a must in any. It's a standard of care in PCI these days, and that is a pre-PCI to assess the diameter, length, and everything, plaque morphology, etc. Because some of the calcific lesions which may not be visible on an angio when we are going and doing a drug-eluting balloon, and if it gets rejected, obviously we have to land up again with the reciprocal. So imaging is a must, and all the more during the procedure or after the procedure itself, so it's better. But my concern is like, injecting a dye through a OCT may enlarge type C or type D to a abrupt closure. So it is better to use IVAS. That is my suggestion. And most of our cases are chip cases. They have CKD failure. So IVAS is a better modality. More than imaging, I want to emphasize the role of FFR and some kind of non-hyperemic ratios. FFR is the must, I can say, because when you are doing limited dye area, the case I have done like ultra low contrast where I didn't want to check frequently with the dye. When the FFR wire is there downstream, the effects, if it shows 0.96, I would literally, after 10 minutes after balloon angioplasty, I have literally ruled out any flow limiting section because the ischemia is not there. Functional testing is all the more important, and obviously imaging may supplement our research. Thanks.
Thank you, Dr. Damodaran. I think we'll move on to the next talk by Dr. Kalaichelvan. Back to the future, DCB used instead of DS for treatment of CAD.
Dr. John, just sorry for one thing, sir.
Yeah.
Dr. Kalaichelvan has got stuck in some of his some conflicting.
So shall we move on to the last talk?
And Dr. Sajan Ahmed, yeah.
So Dr. Sajan Ahmed is going to talk on how we can confidently expand our DCB practice. Over you to Dr. Sajan.
Yes, sir. Good evening. Am I audible?
Yeah, we can hear you.
I hope the slides are visible.
Yeah, we can see your slides here.
Yes. Good evening, everyone. Respected moderators, expert panelists, and dear friends. So I have been asked to talk about one of the expanding indications and how we are probably pushing the limits of the indications. So this is the topic that was given to me was shock and coat. I should appreciate the ingenuity of the title that was given. Anyway, it was this patient was a 71-year-old male. He came with an acute coronary syndrome, a non-ST elevation MI. He had previously undergone PCI for earlier, a few years back. He had a good LV function. He was diabetic, and he happened to be the relative of our hospital's chairman. So this was the angiogram done through the radial route, and this is the right coronary artery. Not sure if you can appreciate it, but even fluoroscopically, there was significant calcium extending from the proximal to the distal RCA. So this was the coronary angiogram. You had a significant lesion in the mid segment along with another lesion in the distal segment, and in fact right from the proximal to the distal segment, it was a diffusely diseased RCA. This is another view showing the mid and distal lesions. It was very difficult to engage the left system with the Tiger catheter, so we went ahead with an EBU 3.5 guide and engaged the left system. which showed again significant calcification in the LAD with tight stenosis in the proximal LAD and osteoproximal LAD disease also, and the TB flow was also less. Yes, you can see in the distal LAD. The circ was decent, and this was a codominant system. You can see the tight lesion in the proximal segment just after the diagonal, along with the osteoproximal disease. So this was probably the culprit with the reduced TB3 flow, and then this was evening, and we even despite the calcium, we went ahead with the PCI. We tried to get an IVL at that time, but with logistics we couldn't get, and then we could thankfully get away with by using a cutting balloon, a Wolverine, and then 3.538 DES was done, post dilated with IVUS guidance with a 3.75 NC balloon. And, so this was a decent flow that we got in the LAD, and a decent looking osteoproximal LAD. So then we planned for a staged PCI to the RCA, and since there was significant calcium, we took up the patient after 3 days with OCT and an IVL to support. So as you can see, the RCA is diffusely diseased right from the proximal segment to the distal segment, and there were two focal areas of stenosis, one in the mid RCA and another in the distal RCA. So we thought we went ahead with an open mind. So we thought if we could get away with because if you want to stent this RCA, we'll have to stent right from the proximal to the distal segment, use long overlapping stents, and in this diabetic patient we thought if possible it would be good to avoid that, but at the same time so we thought whether we could get away with the focal treatment by modifying the calcium initially, and then assess by imaging, and then see if we can do focal treatment with DCB at these two particular locations, and then leave the rest of the RCA for medical management. But at the same time, we also thought that if on imaging or during after dilatations, if we have to stent it, then we would of course go ahead and stent right from the proximal to distal. So in the use of IVL with DCB in peripheral arterial disease, well described. This is from 2023, 55 patients with 71 lesions, and the bailout stenting was only 7% in the peripheral system. But in coronaries, use of IVL followed by DCB without stenting, the first report came from Singapore in 2021, and the same group published their 7-patient series in JAC 2022 as part of the TCT Asia Pacific, I suppose. And there again, they had a series of 7 patients, and 6 patients they could get residual stenosis of less than 30%, and 1 patient had a residual stenosis of 50% with good outcomes and follow-up. So there was a tight lesion in the mid RCA, so we pre-dilated first with 2x12 NC balloon, and then did an OCT run but we couldn't track the OCT catheter distal to the across the distal lesion. So first we imaged the proximal to mid segment. This was the Ultron one and the Obstar catheter. So this is what we saw on the first pullback of the mid lesion. This is from proximal to distal. You can see the co-registration has been done. The marker is moving, and it's moving towards the mid RCA after the RV branch. That is the tightest segment, and then there is a lot of calcium, as you can see, extending from the proximal to distal. So circumferential calcium, but and at the mid region where there is a tightest stenosis, near that there is also a calcium nodule, a non-eruptive nodule also. So this was the proximal to mid distal lumen diameter. As you can see, it's 0.9. So the mid RCA had the tightest segment, and which was looking like this, like a pinhole. So we further pre-dilated with the 2.5 NC balloon in the mid segment and in the distal segment, and then we could pass the OCT catheter to the distal lesion and to see the distal lesion. So here again, you can see that the mid portion had actually the lumen area. There was a gain. There's a mild dissection related to the balloon. And the distal lesion, of course, again, there is significant luminal narrowing with calcium. We used a 3 mm IVL balloon at the distal. Gave 2 cycles distally and in the mid segment also 2 cycles. And in the OCT imaging, apart from these tight areas, we found that the rest of the RCA, even though there was disease and there was calcium, we didn't think that the lumen. We thought that the lumen area was good enough, and we wouldn't have to stent the entire RCA if possible. So after the first round of IVL, this was the OCT, the third pullback after the first 4 cycles of IVL. So this is from proximal to distal again. You can see the mid segment had really improved. There was good lumen gain. While going on to the distal segment, there was improvement, but not good enough. So so there was significant improvement from 0.9 to 2.4, and so we went ahead with the second. We thought we'll give more cycles because we wanted to preserve the IVL runs for in case after the OCT we thought we'll have to shock the other areas also. But now we thought, okay, we'll use up all the shock waves for these 2 lesions. So we tried to track the IVL catheter the second time after the initial dilatations. It was not easy to track, and the catheter was backing out. So then we used the guide +2 and then tracked the IVL through the guide +2 and gave the rest of the pulses distally and proximally. After that, again from the distal, we took an OCT run because we wanted to know what is happening with each step. So this is after the second the entire IVL round. So you can see from proximal to distal. The mid segment was really gratifying to see with a bit of cracks, and this was the distal. Okay, but not quite good enough probably. So this was the mid segment vessel diameter, as you can see. Then we further went ahead with dilatations with the 313 scoring the Aperta balloon, and again followed by a 3 into 15 mm NC balloon. So following IVL, Aperta cutting balloon and scoring balloon, and then the NC balloons. And then we took the final, pre-final shoot to decide whether finally we would be doing DCB alone or go for stenting. So this is the OCT, and the pullback after the treatment with IVL, Aperta and NC showed symmetry flow, no significant dissections, good lumen gain in the mid segment, and the distal area also appeared better, even though not quite as good. So this was a pullback. So we went ahead with DCB treatment, 3 into 20 paclitaxel DCB in the distal lesion, followed by another DCB of the same length, again paclitaxel 3 into 20. And then, as you can see, we just injected some contrast just to see if the vessel is getting occluded distally. It was one of the techniques used by Dr. Kukuli from Lucerne. He's into a lot of work with DCB. So this was the final picture that we got after the DCB treatment. Symmetry flow, no significant dissections, and decent lumen gain, and the final OCT after the DCB, post IVL and DCB from proximal to distal. You can see that area has been really opened up, some cracks, and residual stenosis was less. So that was the final result that we got. So thank you very much. I think with new technologies coming up, even though we adapt these things very fast, I think it's good to be humble initially and follow up such patients in whom we use it for the expanded indications, and be beware, or probably remind ourselves of Sir Hutchison's prayer that too much zeal for the new and contempt for the old may not always be good, but that is how science progresses, by pushing the borders and expanding indications, and then following up these patients to see what really happens. Thank you so much. So I think it's with imaging we get to understand what happens inside the coronaries in a better way, and probably improve upon our work. Thank you so much. You're not audible.
In nature of the use of drug-coated balloons in these sort of calcific vessels, large vessels, are there any trials?
No, sir. In fact, there were no trials, sir. In fact, I read these articles because my primary objective was, if possible, not to stent the entire RCA from proximal to distal. So I was just thinking, going up with an open mind to see what happens with each step, and then take it at one step at a time. But in fact, after the case, because I didn't know, after the case, the technician who came to assist for the IVL said that he's seeing this for the first time. And then I thought, okay, then I reviewed the literature and found that the first report was in 21, and then it was a small series was done it came in JACC. So I'm not sure if I would do it in all cases, but in this particular case, it worked well. And I don't say that every long lesion calcified we should do this, but probably individualizing would help. This is one other way to go about in particular situations.
Yeah, I think you got a very good result. Probably you'll have to just follow him up.
Thankfully, yeah, follow up will be also important. Yes, thank you.
Thank you, Dr. Sargent, for that nice talk. So I think we had a series of nice talks. Dr. Jaber talked to us on how drug-coated balloons can be used instead of drug-eluting stents in bifurcation lesions, small vessels, and also in some large vessel de novo lesions. Dr. Arun Gobi emphasized the importance of preservation of vasomotion with drug-coated balloons as compared to the use of drug-eluting stents in various subsets of patients. Dr. Damodaran showed us some complex cases where he emphasized the importance of imaging and physiological assessment while choosing your drug-eluting stent versus a drug-coated balloon. And Dr. Sargent also showed us a nice complex case where he treated a diffuse RCA calcific RCA with a drug-coated balloon with good result. So there are some questions from the participants. Someone wanted to know about the trials of the Protege drug-coated balloon. So would someone like to give us some data?
Yeah, sir. In fact, there is a study called Pearl study, sir, which is basically a paclitaxel eluting angioplasty real world data. This was done at Netherlands at 4 centers, and there are about 513 patients were enrolled. And these patients, sir, I would say this patient was basically a patient with diabetes, patient with they had instant restenosis twice, and then these patients were also those patients with complex C lesions. And when these patients were studied for a period of 2 years, what is very striking in this clinical trial that the overall this was patients of ISR and small vessels, and the TLR was basically found to be 11.2% at 2 years, which is if you see and compare this with Daedalus study, which was about 15%. So therefore you have a data which is showing a very positivity towards having a reduced amount of TLR. So this, and about 9.3% in patients, the MACE rate was with a small vessel. So all in all, it was a very encouraging trial and a very real world what you see in real practice. Those kind of patients will enrolled in this study, and this goes on to prove the efficacy and safety of this particular drug-eluting balloons. Hope this answers the questions.
Someone wanted to know what was the incidence of bailout stenting after the use of the Protege balloon.
Sir, as per the data which is there in The case of Pearl study, it was about 1.8% of the patient out of 513 patients. This was the number of patients which required a bailout stenting.
So is Translumina the only company where you have a semi-compliant and a non-compliant balloon, the drug-coated balloon?
Yes, sir. We are the only company in the world, sir, having both semi and the non-compliant balloon. Especially non-compliant balloon is well suited for your patients who are in ISR. And in fact, in India, we have yet not introduced, but internationally it is available. Dr. Oscar may be able to throw some light on the NC. Dr. Oscar, if you're there, if you can answer, because he would have that experience of using in the NC balloons.
Yes, we use these new NC balloons, but what I want to emphasize, what is very important, you have to well prepare your lesion. And drug-coated balloon is usually only to deliver the drug to the lesion, not to prepare it. You have to be completely sure that your lesion is prepared using the balloon one-to-one to the vessel. So remember to do it, and then you will have a good result when you take your drug-coated balloon and just deliver the drug to the lesion.